Is it now visible?
Yeah, it's introduction slide. You can now it's moving.
It's moving, right?
Yeah.
So
Moving.
you could
Yes.
able to see this slide, right?
Yes.
Yeah.
Yes.
And yeah, so I was telling about the history of the ocular medications. Then later on, these apothecaries have particularly designed a purified, the ophthalmic medications, and this were being commonly used as a plant-based. So initially, the early antiseptics like vinegar solutions were being introduced high to treat, ocular medicines. And later on, during a kind of, where the Robert Koch and the Louis Pasteur introduced sterile preparations, and they have given, they are the legends of microbiology. And then where they found the, bacteria, and this is the reason for the infection, and they came up with the different infections and understanding the biology of those microorganisms. Then later on, so once they identified the pathogen which is creating an infection, now they wanted to really eradicate those using certain medications that is being named as antibiotics, that basically works against bacterial or fungal bacterial pathogens. And anti-infective, it's like commonly towards all the infective agents. And then later on, the artificial tears developed, dry eye diseases were been identified, discovered, and then its pathology were being studied. And glaucoma, slowly now this drug delivery has been advanced to a sustained release formulations, nano emulsions, and preservative free systems. So this is how, since the history, and even till today, we are being evolving. And why the pharmacokinetics very important in eye is because of the understand the drug behavior within the eye. So eye works like, eye is immune privileged, and the mechanisms which happens within the eye is very different, and it determines the different behavior. The way the drug enters and then distributes within the eye is entirely different. And there will be, it's very important to understand how long the drugs stay within the eye, which drugs are compatible to the eye. These all things very important to understand before bringing any medications within the to the eye. And to optimize the drug delivery also, in case of solutions, hydrogels or nanoparticles, which is being like this, these are the different drug delivery system which is being introduced inside the ocular field, just to improve the bioavailability of those medications which is being, used with these technologies, to improve the bioavailability within the eye, or to within particular ocular tissues, and to ensure the efficacy and safety of these medications, and to bring the translational research, and to innovate the new different type of, ophthalmic therapy, and with advanced drug delivery systems to the eye. And let me start with, bringing to your attention with the different routes of drug administration. Can Sujata please mute your mic? Yeah, thank you. Let me first introduce a route of drug administration. We administer the drug to the eye in terms of topical, as an ointment. You directly put on the surface of the cornea, and subconjunctival injections where you administer drug between your conjunctiva and sclera, and there are peribulbar injections where you inject the drug outside the, muscle cone of the orbital space. And if you inject inside, then it is called as a retrobulbar injections. And if you are injecting the drug same between your 10-ounce capsule and sclera, it is called as a, that is like episcleral place, we say, that is a sub-10-ounce injection. When we are injecting the drug in a anterior chamber, like directly into the aqueous, that is intracameral, intrastromal, that within the cornea you are, in the stromal space, if you are injecting any drug, that is intrastromal. If you are injecting the same drug in the vitreous cavity, that is intravitreal. And the same drug, when it is being injected between the sclera and choroid, where there is a potential space between, the recently discovered in 2-3 decades back, so that is suprachoroidal injection. And between the neurosensory retina and RP, that is subretinal injections. And there is also, whatever the drugs that you are taking systemically also enters inside the eye through the blood retinal barriers, that I will discuss in a while. So when it comes to a topical ophthalmic formulations, we, the 2.2 billion people worldwide have an visual impairment in one or the other way. So nearly 50% of them can be treatable or preventable with proper therapeutic interventions. Most common dosage form we are using in ophthalmology is an eye drop. So what eye drop basically contains? It basically contains an active pharmaceutical ingredient which is responsible for the intended action that we are desiring for, along with some excipients in which the active molecule is suspended with. So basically those excipients are, the inert substance and it prevents the drug to undergo the degradation, and it keeps the drug in certain stable form. Uh, Also, it improves the corneal bioavailability of the desired drug that we are having, and directly influencing its therapeutic success. Today it is very important that, its market is very huge, and the market is going to again get rise by 4.7 to 7.2 percentage, that is around 22 to 26 billion US dollars. And again, there are several available medication range we have, from hundreds to thousands of formulations are available, uh, in ocular space itself. So what these excipients basically have, uh, this have viscosity enhancers. So other than our active drug, I'm talking about, is have viscosity enhancers, which basically keeps the active molecule on the surface of your eye for a longer period of time. Permeability enhancers. Uh, so basically this basically enhances the active pharmaceutical ingredient towards your eye. It basically alters your tight junctions so that more amount of drug enters your eye. And solubility enhancers, stability enhancers like cyclodextrins, surfactants, where if suppose you are using a very lipophilic drug, it basically helps, to keep the molecule which is compatible to your hydrophilic surface. And osmotic agents, it maintains your osmolarity similar to your tears. And there are buffering agents, antioxidants, preservatives, lipid based carriers, mucoadhesives, and some gelling agents. Basically all this are to enhance the stability of your active molecule, and also to improve the bioavailability of those molecules so that the drug can work at its best. Preservative is again to prevent the microbial contamination of those eye drops, because anything in the liquid form are prone to contaminate. So the preservative is also one of the important component. So how the drug enters when you add one eye drop on your surface? So it first has to touch its precorneal barrier, and it has to get mixed with the tear surface, and slowly it enters the cornea. In this blink of time, it has to undergo several process. It gets mixed to a tear film, it gets entered into the nasolacrimal drainage, and it gets lost while blinking also. And so it's not that 100% of a drug is entering inside the eye, only 5% of what the active pharmaceutical ingredient enters. So if you are adding 0.5% of moxifloxacin, it's not that 0.5% of moxifloxacin is entering. 5% of 0.5% moxifloxacin actually enters inside the cornea. So that's how and it is not always a 5%. If suppose you are using some high lipophilic drugs, it is less than 5%, 1 to 3% in most of the sense. So it is not that whatever the concentration you are using is going to be effective, like you are injecting something in intravenous or directly inside the vein. This is not the same with ocular case. And once it enters the cornea, it gets mixed with aqueous humor, and it enters the anterior intraocular tissues and posterior tissues. It gets mixed with vitreous humor, retina, and it gets eliminated to the blood vessels present in choroid or retina. So this is the fate of the drug which is being applied topically. And what basically prevents, what basically is involved in making this eye drop available less than 5%? Number one is anatomical and physiological barrier. So we have a very less conjunctival sac space. We have only 25 microliter of conjunctival sac space, though it can able to accommodate only 25 microliter of your teardrop, and your ocular surface volume is only 8 microliter. So human eye can accommodate hardly 30 to 50 microliter of your the drop size that we are applying. And we blink 15 to 20 times per minute, and we have a tear turnover of almost 1 microliter per minute. And third is tight junction proteins like claudin, occludin, jam A, zo1. So basically all these tight junction proteins present between the corneal cells prevents the drug to enter within the cornea. Basically those proteins blocks the paracellular transport of drugs. Paracellular transport means the transport of drugs between the cells present in a particular tissue. And next is efflux transporters. So when you are adding some drug on the corneal surface, there are certain efflux proteins present on your cornea will push those drugs outside the cornea, and there are metabolizing enzymes which rapidly metabolizes those drugs in an inactive form. So all these are limiting factors that why even after why this ocular viability is so less. And there is a nasolacrimal drainage I told before, and this happens 1 to 2 microliter per minute in average, and up to 80% of an eye drop drains within 2 to 3 minutes in the nasolacrimal drainage, and it either enters the systemic circulation. And also the corneal barrier itself is like a sandwich. The corneal epithelium is a lipophilic, which means it is more towards lipophilic molecules, and stroma is 90% of the corneal composition, where it is hydrophilic, and again endothelium is lipophilic. So the molecule can't be either lipophilic also or hydrophilic also. The molecule should be having a log P of 1 to 3, so that it crosses a different type of layer with different properties and enters the eye. And in terms of drug perspective, when we see the molecular size of the drug that we are using should be less than 500 Daltons, that shows a good permeability of those molecules within the eye, and like we cannot use a larger molecules as a topical eye drop, since it never enters inside the cornea. And also as I told, that the cornea works like a lipophilic, hydrophilic and lipophilic sandwich. So the log P of the molecule is supposed to be around 1 to 3 to get successful in ocular therapeutics. And it after entering also, there is a high probability that the molecule we are using as a eye drop have a binding affinity with tear albumin and melanin. So again it prevents the therapeutic effect. It just holds like a receptor, and it don't allow the drug to freely available. So only freely available drug works in the receptor that we intended for. So if this kind of non-specific binding also prevents the drug to act. And the drug should be again should be soluble and as well as stable. So poorly soluble drugs or highly lipophilic drugs really have a problem here. So poorly soluble drugs, either you have to use a suspension. When you use, it's very irritating. So the drug should be freely soluble in the liquid. That is a very important criteria. And highly lipophilic drugs do not enter the stroma itself. Again, there is a problem. And it should not be a substrate of efflux transporter. And like I told, that drug have affinity to bind different proteins like tear albumin. So if that is a substrate of the efflux transporter, it directly pushes away the drug. It do not allow the drug to enter inside the corneal space itself. And again, the ionization pattern of the drug should be compatible with your tear. So only when the drug is in unionized state can enter. If the drug is undergoing ionization and it attains some charges after adding in your tear, it never enters. So there are several drug related perspective which really restricts the drug to enter the cornea and bind to the particular receptor that we intended for. And this is some description that you may get some idea to describe how this efflux transporter works. There are certain transporters that takes the drug inside, like MATE1, OATP, 1PA2 or B1 you are saying, and there are some proteins that really pushes the drug outside. Those are called as efflux transporters, and those which takes the drug inside is the influx transporter. So here you can see the lot of efflux transporter, like PGP, or there is MRP protein. So this P glycoprotein, or this multi drug resistance associated protein, all these drugs, all these transporters basically pushes the drug outside the cornea, so it not never really allow the. And I think the evolution has been developed this way, that this cornea is directly come in contact with the environment. So whenever we are facing anything, this has to push, this is also very important to push the environmental toxins outside. So in certain way this is good, but in terms of therapeutics we see it as kind of a problem. And here I wanted to give an emphasis on blood ocular barriers also. There are two type of blood ocular barriers that basically is the deciding factor, like how much the drug being given systemically can enter the eye, or how much the drug being so how much the drug that you have administered within the eye can eliminate from the eye. So these are the deciding factors that tells, or that basically decides the bioavailability of any drug within the eye. Blood aqueous barrier, you can see in the figure where there is a non-pigmented ciliary epithelium. So what makes the blood aqueous barrier is a non-pigmented ciliary epithelium, and iris capillary tight junctions makes the part of blood aqueous barriers that basically controls the plasma to aqueous exchange. So plasma is a blood component, right? So from plasma the aqueous humor is getting produced. It is basically a filter that filters the plasma and it produces the aqueous humor. And there is a tight junction proteins present within these cells, acts as actually filter that purifies this plasma. Plasma have a protein proportion of 45% to 50%, whereas aqueous humor have a protein proportion of only 2%. So it is a very good, if any problem in those barriers will create a mess in your anterior chamber. And there is a blood retinal barrier which is of again two types. One is inner blood retinal barrier and outer blood retinal barrier. Inner blood retinal barrier is basically a retinal capillary endothelium. We can see here, like I think you can see my cursor, cursor moving. So inner blood retinal barrier is a retinal capillary endothelium, and outer blood retinal barrier is a retinal pigment epithelial tight junctions. Again, this acts as a filter and deciding factor of what type of molecules or things can enter towards the posterior segment of the eye or getting eliminated from the posterior segment of the eye. It maintains the retinal homeostasis and protects the neural retina, and it is very important for our vision. So this is very important gatekeepers of how good is our vision. So any problem in this blood retinal barriers leads to several ocular conditions, and we can list, like there are in many other disease complications also. The first thing getting affected is this blood ocular barriers only. So I wanted to give an emphasis on few drugs which we are taking systemically can enter into the eye through this blood aqueous or blood retinal barriers. One is acetozolamide. It crosses the blood aqueous barrier and enters inside the ciliary body, and it decreases the aqueous humor production and thereby decreasing the intraocular pressure. And the corticosteroids, again it diffuses both through the blood aqueous barrier as well as blood retinal barrier, and it produces the anti-inflammatory effect in the retina or uvea. So these are all the area of ocular tissues were being highly vascularized. So those kind of tissues having a problem in which the vascularization is more, you prefer taking systemic medications so that the good amount of the drug is entering in those areas to prevent prevent you from the damage of those particular tissues involved. So it's not that always you have to take an ocular medications. It's not that sometimes it's been prescribed to use systemic medications for an ocular complications. And there are all the problems which I described so far, like that those efflux transporters, neither it's blood aqueous barriers or the complications in the corneal corneal tissues that restricts the bioavailability of ocular medications. We can see how we can improve them. Either you can increase the corneal contact time so that drug can stay on the ocular surface for a longer time for the action. So, and there are few technologies there been the recently being introduced, and there are these are very good technologies that can basically improve the ocular bioavailability, like nanomeshel, nanoparticles, nanosuspensions, either it's a liposome, neosomes, this microneedles, hydrogels. There are few good number of technologies which really improves the permeability and the contact time with the cornea. And this also controls with the controlled pH, osmolarity, and exact drop volume. So it brings very good amount of penetration and achieves the bioavailability and makes the works to at its best. Now we studied about the absorption, how the drug enters and what are the difficulties the drug faces while entering, and now how the drug is getting distributed after getting entered. Now when you put the topical eye drop, so how long it stays. It achieves the maximum drug concentration in aqueous humor within 30 to 60 minutes. But when you taken the drug intravitreally, it achieves its Tmax by 2 to 6 hours. Tmax is basically the concentration, that the time at which it attains the maximum concentration in particular compartment. Eye we can divide in different compartments. The vitreous humor is one compartment. The aqueous humor is the anterior segment is one compartment. We can even make hypothetical compartments, like the tissues present in anterior segment is a third compartment, or tissues present in the posterior segment is fourth compartment. So there are different mathematical models, but I don't want to describe all of them. But here what I'm trying to say is that we can able to study the drug concentration in the different compartments in different ocular fluids, and at different Tmax, the how much is the maximum concentration of the drug is reaching at the particular compartment or at the particular ocular tissues, and at what time it is reaching, so that we can expect the pharmacological action at that particular time point. And we can manage the therapy. So all the frequency of drug administration and dose of drug administration, or all this based on the Tmax, Cmax, and pharmacokinetic parameter, and where it is getting distributed, how fast it is getting eliminated, with that only. For example, I'm here putting one example, like the intravitreal injection. Suppose I've given 50 microliter of the intravitreal injection. It attained its Cmax in the vitreous compartment at 8 microgram per ml. Suppose I collected vitreous humor at the second hour and tested. I measured the drug levels. It is showing 8 microgram per ml. And then I also enucleated the eyeball, removed the retina, and measured the drug level in the retina. It is 2 microgram per ml. Now I wanted to calculate the tissue partition coefficient. How much? So it basically tells how much amount of injected drug in the vitreous humor has entered the retina. So the problem, I might have injected for some retinal condition. So my goal is to attain that particular drug in the retina. So if I wanted to study, I first have to take the ratio of concentration attained in the retina to the concentration that has reached in the vitreous humor at 2 hours. So which is 2 divided by 8, and it is like the tissue partition coefficient we say is 0.25. So this is some basic concept, like how there are hundreds of equations, but I just want to put 2 equation. And what extent this is getting distributed is the amount of drug that you put in the eye and concentration in ocular fluid. For example, this volume of distribution directly reflects the extent of tissue partitioning, and larger the volume of distribution is considered as high tissue binding. And now comes the drug metabolism. So now, okay, the drug is distributed. Now how it is going to get metabolized? it cannot be, staying in its active form for a so long. Staying in active form for a so long is a problem. It creates unwanted toxicity. So how the, the eye is taking this drug and metabolizing to a different forms. So there is a two type of drug metabolism. It happens in two phases: phase 1 and phase 2. Phase 1 is, oxidation, reduction, hydrolysis. Basically this oxidize, reduce or hydrolyze the active drug into an inactive form. And also, the second phase, okay, now it's made the drug as inactive, and now it conjugate the drug with certain agents present endogenous, like glucuronic acid conjugation. There is a sulfate conjugation, acetylation, methylation, the nucleoside or nucleotide conjugation. There are different conjugation mechanism. Basically a new group were been introduced in any of the functional group in the drug, and so that helps, basically that improves the water solubility of that particular conjugate, and so that it improves the elimination of that particular from the eye or even in the body. So here we are talking only on the eye, and then so yeah, we are now restricted to the eye. So this happens within the cell, and there is an export transporter where so the inactive metabolites will be eliminated, and that will be removed or enters the systemic circulation and gets the removed from the body. So like, what are the different type of enzymes? So what are those enzymes which is making this drug inactive, and do all these enzymes were being expressed in different type of tissue, ocular tissues? Yeah, of course. It is the site 450 is an enzyme or esterase which has been widely expressed in the corneal epithelium itself. So as I told that, so the drug will be started getting inactivated in the cornea itself, and corneal endothelium also have esterases, and iris ciliary body, again the drug started metabolizing there, and retinal pigment epithelium, whether it might be in neurosensory retina. So everywhere these enzymes are present, and that helps in metabolizing the drug. And also even the metabolism, even the enzymes which is responsible for making the phase 2 metabolism possible is being expressed throughout the ocular tissues. That basically detoxifies even the environmental toxins, or per se the drugs that we intended to produce the pharmacological effect will be eliminated in this route only. So even almost like retinal pigment epithelium, retina, lens epithelium, everything have their own protective mechanisms, that it won't keep the drugs for a longer time, and it always ready to metabolize and eliminate. Okay, now the metabolism has done. So how these drugs are coming out, and I just want to give a few glimpse on what are the factors that affects the ocular metabolism. The person with different age, or are already having different disease conditions, may metabolize the drug differently, or inflammatory conditions, if they are already having inflammation, they may have different type, they may undergo different phases of metabolism, or there might be a slow metabolism happening with them, and they may undergo toxicity. There is a high possibility, and if there is any breach in the tight junctions, again they may have different bioavailability profiles. The drug concentration, formulation type, and the genetic polymorphisms present in those enzymes also affects the how much drug to enter, and how much drugs can be eliminated. So now the drug is getting metabolized. How it is getting eliminated from the eye? So since the time that you applied eye drops, it started getting eliminated, like nasolacrimal duct, and there is a the conjunctival or scleral absorption happens, where the drug also touches the the conjunctiva, where there are a lot of blood vessels. So that can remove the eye the medications from your eye drop, or reduces the corneal or ocular bioavailability. And there is a conventional pathways through which the trabecular meshwork again eliminates the drug, and also there is a uveoscleral outflow pathway. Once the drug enters inside the aqueous humor, it gets eliminated through a uveoscleral outflow pathway. And there is an through the anterior route, there is aqueous outflow through which the drugs get eliminated. In posterior route, when we say that, it basically the drug enters the retinal or choroidal circulation, and from which there are multiple active transporter present in the retinal pigment epithelium also. and so from which it gets mixed with the vascularity in the retina or choroid, and from there the drug will be taken away from your eye. And this is again the factors influenced by the molecular size, solubility, and ocular physiology. Yeah, so and when we say about the ocular clearance concept, I wanted to emphasize here on the rate of drug elimination from the different ocular compartment is the ratio of the rate of elimination to the concentration actually present. So how fast the drug can eliminate from the aqueous humor is like 1 to 3 hour, whatever the drug you are giving, it is gone from the aqueous humor. And when if it comes to the vitreous humor, yeah, really the drug stays quite a long time. If particularly small molecules, it takes quite a long time to get away from that particular vitreous humor, because that is jelly and the diffusion happens from the area where you injected, and it's the spread throughout the vitreous humor and getting mixed with the choroidal or retinal vasculature. It takes really 10 to 30 hour and to get cleared, and there is a rate of clearance from the ocular compartments like 0.05 ml per hour to 0.5. And if it is a proteins or antibodies, since the molecular weight is so large, it just do not get eliminated. It takes really a good time. It stays there for 3 to 10 days within the vitreous humor, that is a posterior segment, and it slowly eliminates, like because of the large molecular weight of those molecules. Like for a best example is anti-VEGF treatment. The patient will come every week to get injected. So those are big molecules. Anti-VEGF molecules like bevacizumab is a very big molecule. So it gets almost a week to get eliminated. So the patient can have the efficacy of that molecules for almost a week. Now, okay, so we have studied about how the drug absorbs, distributes, and metabolizes, and now eliminated, and how it differs from patient to patient, or how the molecular size of the drug impacts. Now, how the drug works. So it works on the receptor or ion channels. It may have a enzyme as their targets, or like a transporters, it may have a transporter as their targets. The principle here, either to activate or to deactivate, or to make them to bring no action to that particular target. So this is kind of layman language I am telling. And so what are the receptor types? Basically there are 4 different receptor types. G protein coupled receptor, where it have a secondary messengers. It releases the calcium and brings the cellular effects, or it undergoes the protein phosphorylation. And this G protein coupled receptor have a link with the ion channels also, where it brings excitability or inhibition in the, either it opens the ion channel or closes the ion channel based on whatever the agonist or antagonist that we are giving. And it produces, the best examples are opioid receptors, muscarinic acetylcholine receptors, alpha beta. So majority of them are G protein coupled receptors. And there are drugs where it directly sits on the channel linked receptors. Basically channel linked receptors are those receptors where it is linked to certain ion channels that only brings hyperpolarization or depolarization. So if the agonist go and bind to that receptor is linked to the particular iron channels that either opens or closes. So that brings a cellular effect. Or so, and then third type is the enzyme linked receptor, where it undergoes the protein phosphorylation. It may undergo gene transcription. So basically here it takes hours to work. Our all the hormonal pathways or growth factor receptor pathways, cytokine receptor, this brings it takes an hour to act. Like there are certain receptors present within the nucleus that when the agonist goes and or drug binds it brings the gene transcription, it alters the protein synthesis and brings a cellular effect. So what basically are the different type of ligands, basically a different type of drugs, what type of reaction it brings to that particular receptor. Either it might be a full agonist, it binds and produces the maximum effect on the positive note, it fully activates the receptor it intended for. are partial agonist. It goes and binds, it do not activate, it do not produce the maximum effect, but it produces certain amount of effect which is not maximum but that is moderate, that is beneficial for the therapeutic effect. Or inverse, it goes and binds to the receptor but produces the negative effect what from what we intend. For example, here is an antihistamines, so we want a histamine, so histamine receptor is a problem, like overactivation of the histamine receptors is a problem, like through the endogenous histamines. So we wanted to bring a negative effect to that histamine receptors, so we use some antihistamines which brings the negative effect on that histamine receptor so that our allergy is being controlled. And also here we have a competitive antagonist. So basically here the intrinsic activity is different. Once the drugs goes and bind to those receptor, it brings no activity, it never, it don't activates, nor it won't work like an inverse agonist, so it basically brings no action. As a result, we get some amount of effect. A best example is atropine. And here the non-competitive agonist, where there it do not have a competition to the existing agonist, it just goes and binds and makes covalent bond. It is the strongest bond, so it do not have any competition. It is the only ligand that is going to bind to that particular receptor with no competition with the agonist. And there are irreversible antagonists, like where it permanently bind to the receptor and it never goes away. Only when the receptor is getting when there is a more number of receptors getting expressed, or that, or it is undergoing a phase change, then only there is a possibility that the new molecule can work. Otherwise it binds so allosteric modulators are those, it have the, suppose like one protein target have, so the protein have different targets, like there are orthosteric site where it is a primary site, there is also secondary site. So that secondary site is basically an allosteric the modulator. So the drug binds to the secondary site and it alters the effect of the ligand which is supposed to bind at the primary site, so it brings a different effect. And silent antagonist is like this ligand goes and binds and do not bring any effect. So there are different type of the agonist, antagonist, there are different mechanisms in which it works. And here what decides what type of interaction any drug makes with the particular the receptor or any targets is, if suppose if for example what I am talking like before, it was if suppose a competitive antagonism or any competitive agonism, it makes a weaker bonds like hydrogen bonds, ionic van der Waals forces. The drug binds, interact with the receptor with the weaker bond, so then there is a competition. If it makes a stronger bond like covalent bond, there is no competition and it makes a permanent bond where the drug effect do not go and it produces a prolonged effect. So this decides whether that drug can be ligand can be competitive to the endogenous ligands, or the ligands can be non-competitive to the endogenous ligands. Or there is a term called affinity, where the strength of the drug binding, so how much strength the drug is getting bound to the receptors, or efficacy is the term, it decides the ability of the drug receptor complex to trigger that particular response, or how much potent it has to work, that determines basically a dose. Some drug even at the very small dose produces a maximum effect, so in that case we say that is a very potent drug. And selectivity determines like how specific that particular drug is binding to the particular receptor, so this determines the specificity or selectivity aspect, like it should not, the drug should not bind to a non-specific targets that brings a toxic effect or side effects. Only when the drug that we intended for a pharmacological action has to really bind the target that we wanted or we expect to bind. If it is binding to some other receptor or protein, it brings unwanted effect, so that we say is that is a side effect or or toxic reactions. And I just want to give on a little example here. So there is a sympathomimetic drugs that brings mydriasis, right, that the phenylephrine, where we could see there is a constriction of the radial muscle, And whereas when we use a parasympathetic drugs like pilocarpine, we can see the constriction of sphincter muscle that brings a meiosis. you know uh, Basically this parasympathetic nerve or sympathetic, uh, the nerves are generally present in the eye, and it is very important to function, or to modulate the light levels to your pupil. And so this is very important. So during the diagnosis, any I think you use lot of homotropin, it's again a tropicamide or trophin, whatever, to dilate and to see what is happening, in terms of testing the spectacles. So in those cases that you wanted to really, bring the mydriasis to the eyes. So it basically, parasympathetic works on M3 receptor, which is present in your iris, and sympathetic agents which present on alpha 1 agonist. That is the exact example of agonism, or this pilocarpine is an the example for agonism in M3 receptors. Where we can see the anticholinergics, right? The atropine, atrophy. This is an basically an antagonist. It works like an antagonist and brings the mydriasis. It basically blocks the M3 receptors, and this works basically as an antagonist and brings the the exactly opposite effect what agonist is producing. So here, when I talk about the adverse drug reactions, we can say adverse reactions can be an unintended harmful response to the medication that occurs at the normal dose for prevention, diagnosis, or treatment of disease. So you use the medication in the normal way. You are really intended to bring some therapeutic, you really intended to make use of that medication for a therapy purpose, but unexpectedly or unintendedly it brings some noxious or the effect that you really do not want. But you have given a normal dose, everything like in the normal manner, in the normal way, like everything is good, but it really brought some unexpected event to a patient. So this is noxious and unintended. So WHO classification for the response to a drug which is noxious or unintended, which occurs at the doses normally used in humans, and it occurs really at the therapeutic dose, and it can happen even when the drug is properly prescribed or taken. For example, the gastric irritation with aspirin, or hypoglycemia with insulin, dry mouth with anticholinergic drugs, and we can say the corneal toxicity or epithelial defect with certain topical ophthalmic drugs. Here is a funny quote: this medication side effect maybe include a memory loss, dementia. So sometimes doctors communicate to us that observing quite a few number of patients, that they inform you prior that this may have this effect, but since that particular medication benefits large number of groups, and it creates side effects only a few number of patients, so they really inform sometimes that it may produce, in case if it produces this reaction, please let us know. So the patient will report to a doctor at that time. And the and again, actually ADR is really the important matter, because it is responsible for major hospital admissions, and it can be sometimes life threatening. And that's why the pharmacovigilance, where it's a study where they study only about the adverse drug reactions, and reporting them to a regulatory body, so that it can be the healthcare workers can be made aware. And also it is a part of post marketing surveillance of any drug discovery. And what is not ADR is that, suppose somebody prescribed the medicine in an overdose, is not an ADR. Somebody intentionally taking the drug too much, that's a drug abuse, right? For example, is an illicit drug. So those are really that is not an ADR. And medication errors, instead of prescribing one drug, the other drugs were being prescribed, that is not an ADR. Again, the treatment failures is not an ADR. There are different type of adverse drug reactions. We can say A, B, C, D, E, F, and A is and dose dependent, and it is predictable. We are sometimes aware that this may happen. So like I told, the doctor may bring into your attention that this may happen while taking this drug. So this is a dose dependent predictable, they inform you before. Example are hypoglycemia with insulin or increased IOP with steroids, because they have noticed a lot before. And type B is really a misery. It's like unpredictable and immune mediated. It happens quite very in few patients, which is either they have to undergo a sensitivity testing before taking particular drugs that they feel is very essential for the disease, otherwise there is no option. So this type of things, so I just want to remember my neighbor who died out of anaphylaxis with penicillin. He went to a doctor where he was being prescribed with penicillin derivative, and without sensitivity testing, so he had undergone a severe anaphylactic shock and went into a coma, and he had died within 2 months. So this kind of severe anaphylactic reactions also happens with certain medications. So that is really sometimes that people should be aware of, and should perform sensitivity testing before prescribing or using certain drugs. And there is a type C is a effect of drugs in chronic conditions where while using certain drugs very long time, that you may have to undergo certain conditions like cataracts from steroids or retinal toxicity with fluoroquinolone long term use. So this drugs, for example, fluoroquinolone bind to the tissues and it stays there for a longer time, and it have very slow elimination half life. So that type of binding creates a cumulative dose accumulation over a period of time and creates a toxicity. Not only retinal toxicity, it may harm other organs in the body also. It's a type D is late onset reactions, the cancer after chemotherapy, or optic neuropathy of with ethyl butanol. So it don't happen just immediately after you are taking drug. It may happen quite long after you are discontinuing a treatment. It may happen later also. So those are type D. That and type E is end of use. It's a kind of withdrawal effect. So you are taking certain drugs, for example antihypertensive drugs. You wanted to reduce your BP, so you are taking antihypertensive drugs. Now you have left the drug to take for 2 days. You haven't taken the drug. Suddenly your BP shoots up. So this is because of withdrawal or rebound effects. And type F is a failure, like it's therapeutic ineffectivity. You are taking antibiotics, the microorganism is already resistant to that particular antibiotic, so it won't work. So where you can find no effect, so this is a therapeutic failure. So basically the therapeutic ineffective. So although you have given the known dose, you have given the normal regimen of therapy, but it won't work. Then later on you come to know that is because of the microbial resistance were being developed over a period of time. So there are related terminologies in associated with the adverse drug reaction. Those are like side effects. This is again unintended effect of drugs, but usually this is very mild and tolerable, and it is not clinically serious. And for example, you get a mild burning after eye drop instillation, but still you need that eye drop instillation so that you can save your vision. So that can be taken as side effect, but can be ignored clinically. And you can consume those type of reactions. So again, adverse drug reaction is, again I have explained all this. And then drug toxicity, it's like very harmful effect due to excess dose or accumulation. Like I told about this chloroquine recently, that it produces a retinal toxicity, right? And there is another drug like aminoglycoside nephrotoxicity. These are all dose related. So either you taken the overdose, or there is impact clearance, like you got liver problems or you got a kidney problems, where those organs could not able to remove the drug from your body, and that's how the dose is getting accumulated in your body, and slowly it started creating an organ failure in your system. And here is a drug allergy. So like I told, this is penicillin anaphylaxis, the story that I have just told 5 minutes back. This immune mediated reactions can happen with anyone. So this should be, people should be aware of the sensitivity testing, and this is again dose independent. It is like very unpredictable, and it can lead to a death. So who are at risk is that those with renal or hepatic impairment, they cannot able to metabolize the drug, or those with genetic polymorphism in either a drug metabolizing enzyme, or the drug transporters which supposed to remove the drug from your body. Any polymorphism, or the mutation in those genes can affect how fast the drugs can get eliminated from your system. So that again vary from population to population. So some people are fast metabolizers, they metabolize the drug very quick, and some are very slow metabolizer of the drug, they metabolize the drug slow, very very slow, and then the drug stays in their system for a longer period of time. And this happens with the food also. Some have metabolic capacity very high, and some have metabolic capacity low. So their weight and everything changes as per that. And age, polypharmacy, you are using more than 3 or 4 drugs at a time, and so it simultaneously working on different receptors and bringing different actions together. So you may have a high probability that you get a ADR. And long-term treatments particularly, or any treatment with a geriatric or pediatric patient, you should adjust the dose. If you are not adjusting the dose, for example, geriatric people, like old age people, metabolize the drug really slow, so you have to reduce the dose for them. For pediatric dose, again you have to reduce the dose based on their body weight, otherwise they also face ADR. And we can categorize the adverse drug reactions either as a mild, moderate, and severe. We can say mild ADR, it does not require treatment change. Moderate, yeah, it requires dose modification or treatment. Severe, it might be leading to a life-threatening condition, or causes severe hospitalization, like the penicillin case. And ADR reporting is very professional responsibility. Even as an optometrist, like if you are coming across certain patients where you are feeling that after using that particular medication, this patient is developing a corneal opacity, you are in a responsible position to report either to your doctor, or your pharmacist, or who is being dispensed the drug. So, and do a thorough examination, or get the thorough history from the patient, what type of medication they are using, how long, how frequent they are using. So every one of us like have this responsibility to detect, document, and report to to the regulatory authorities, or to the administration that we are working on. And when we say ocular toxicity, it can happen with systemic medication also. You are taking some systemic medication, it ruined your vision really, it enter your eye, and it created retinal toxicity. Again, you are suffering with that. Or some topical drugs that you are taking, it ended up with a corneal opacity, or unknowingly that you came into an exposure with an environmental or occupational toxins. So this also comes within ocular toxicity. So whatever there is a to develop an ophthalmic products, there is a strict regulation. It has to get approval either from FDA or European medical agencies, and it has to undergo certain tests before introducing a particular medication into the eye field. So the Organization of Economic Cooperation and Development has introduced or recommended certain tests to be performed before any drug can be entered inside the the ocular before any drug were being introduced as an ocular drug. Here why there is an ocular vulnerability in particularly unique to the eyes is because of they are very sensitive to preservative. We have a lot of pain receptors. There are 100 more pain receptor present in your cornea compared to your skin. So cornea is very sensitive to pain and pain perception. So particularly this is sensitive to those preservative that you are using for a long time. For example, either might be a preservative used to preserve that the patient with a dry eye disease, or a patient with glaucoma, they are using a medication for a long time, and whatever the preservative is present in the topical medication is ruining their vision and creating ocular toxicity. So this is very common, the eye is really vulnerable in those cases, and lens sometimes prone to cataract formation. Retina can undergo phototoxicity, or it's very rare that any drug which we are using ocular for ocular use is creating a systemic drug toxicity. But still some beta 2 blockers can really changes your heart rate, and it may bring brachycardia. And optic nerve is again vulnerable to mitochondrial toxins. So there is a limited regenerative capacity in retina or endothelium. Even corneal endothelium have a very limited regenerative capacity. Once this toxicity being produced, it takes really a good time to recover and come over again. And what mechanism generally these drugs produce ocular toxicity is because of either it creates a lot of reactive oxygen species that result in oxidative stress and creates ocular complications or mitochondrial dysfunctions. It creates inflammation or cytokine release. It either disrupts the barrier. So the people with a barrier dysfunction are again highly prone to undergo ocular toxicity. And some drugs that activates the apoptotic or necrotic pathways are really can create the ocular toxicity. And so there are certain guidelines. I told that OECD is recommending to really perform before introducing any drug in ocular use. Is there are certain in vitro models where you put the drug directly on the cell lines to see what type of the changes that the cell, like at what concentration the cell starts dying, and what is the rate at which dying, and how much proportion of the cells were dying. So all these things you can monitor in vitro. And once you get an idea, like see this heat cam assays, like hen eggs, chorioallantoinic membrane, where we exposes the chorioallantoinic membrane of the egg, where we can see some vasculature. You put the eye drop on that vasculature. Now the vasculature should be as normal as like when you are putting placebo. If the vasculature is undergoing some kind of changes, then you can really sense that this drug is not for ocular use. So you get the clue there. And if you are really using some drug for a the vitreous chamber, then you have to really check that the retinal pigment epithelial cell, and you have to use and check its toxicity. If you are using if you are really wanted to use or bring some topical medication into a market, then you should have the data for what is the toxicity profile of that particular drug with human corneal epithelial cells. And again there are some ex vivo models called bovine corneal opacity and permeability, where you can study, there is a kind of setup where you can place the cornea in, like, and you can expose the drug on their surface, and how much amount of the drug is entering the cornea. There is a collection chamber in which you can collect how much drug has been passed, and you can measure the levels so that you can optimize the dose. And there is a in vitro models called race test, where you expose the drug on the live rabbits, and in a different frequencies to ensure there is no corneal opacity, conjunctival redness, chemosis, and iris involvement. So with all this we if suppose like you are introducing some drugs to a retinal vitreous chamber, you have to again inject that drug in a rabbit model to see the drug is safe. And it has to be confirmed through the imaging, and it has to be undergoing a regulatory submissions. Yeah, excuse me. Yeah, eye is again metabolically very active and rich in nerves. So vitamin is very important. It requires vitamin is essential for the eye functions. But a lot of us do not give emphasis on how much the vitamin is important to normal eye functions. So there are certain essential minerals like copper, iron, zinc, calcium also play a very important role, and particularly zinc is having an abundant role in retina. Adequate vitamins and trace elements are very essential for normal eye development, visual functions, to protect from oxidative stress, and to overcome the deficiencies which lead to a reversible or irreversible ocular diseases. And there are certain vitamin A deficiency. The vitamin A is very important, particularly in terms of the metabolite which is being generated from the vitamin A, like retinol. There are several important metabolites that is being involved in the visual cycle, for which the vitamin A is very important. And vitamin A deficiency again lead to a night blindness, xerophthalmia, corneal ulceration sometimes, and also in severe cases it creates irreversible blindness. So to maintain the normal ocular health, vitamin A, similarly vitamin D is involved in the immune modulation, inflammation, and also having anti-angiogenic properties is being proved in certain research. So people are linking dry eye disease with the vitamin D deficiency. So this vitamin D supplements a certain way that it helps dry eye disease people to overcome that condition, to improve their condition better. So like how there are several other vitamins like vitamin B1, B6 is very important in maintaining the retinal health and optic neural health. So the ascorbic acid again to prevent the lens to undergo opacity or cataract formation, and vitamin E is again emphasized to be essential for the retinal and retinal pigment epithelial health. And folic acid is very important, and if there is a folic acid deficiency, the people undergo retinal vein occlusion. And again I emphasized before that the zinc is very essential for the retinal and retinal function, so it is being linked with several diseases. With this I am concluding. I think I have covered the topic.